Hi, I'm Dr. Duru Shah, the President of the PCOS Society of India. I welcome you to our program called Dialogues and Directions, which the PCOS Society of India is hosting to propagate the 2023 International PCOS Guidelines. We all know that PCOS is a well-known entity now with the amount of research which is on, and with all the guidelines and all the research papers which are available to us, there is much more clarity than it was before. Realizing the growing epidemic of PCOS, we put together a society called the PCOS Society of India in 2015. And we had Dr. Anuja Dokras, Professor Anuja Dokras, from Pennsylvania, from the Penn University, who had helped us launch it. And since then, we have been focusing on the subject of PCOS, which has been of tremendous interest to me and to a lot of other physicians. In the past, PCOS occupied just about a chapter in gynecology and maybe an hour or two in a meeting, which was of gynecologists for almost 2 days. But today, it has grown, and we have a 2 and 3 day conference along with multidisciplinary experts who are engaged in the treatment of PCOS. So I think we've come a long way. And these guidelines, which were first introduced, the international guidelines, which were first introduced in 2018, have been now updated in 2023 through the effort of a huge team of experts and a lot of people who have put in a lot of effort to create them. And we are in the process now of disseminating them, especially in our country, where we have a lot of diabetes in our country. We are one of the largest population in the world with diabetes, and PCOS somehow seems to be a precursor to it. At the same time, we know that cardiovascular disease is very much prevalent in women who have metabolic syndrome and diabetes. So there's a lot of discussions we have had on the physical health. But how many people are discussing the mental health of PCOS women? And it's important for us to discuss that because they go through a lot of stress, anxiety, depression, etc. And today we have none other than Professor Anuja Dokras with us, who will discuss the mental health issues and well-being of PCOS women. If I have to introduce Anuja, I will call her Anuja because she's a dear friend, and she has been one of the experts chairing the groups which were discussing mental health. She's a founder professor of women's health at the University of Pennsylvania and executive director of the Women's Health Center for Clinical Innovation. She's wearing multiple hats in this university, and she's also the medical director of reproductive surgical facility at the Penn Fertility Center. Director of the Pre-Implantation Genetic Diagnosis Program, Director of the Penn PCOS Center, a multidisciplinary center, providing care to adolescents and women at all ages of PCOS. Innovation in women's health is her current interest, and she's set up a huge center called Innovation in Women's Health. And she's also interested in the cardiometabolic risk and mental health of PCOS, including, of course, IVF and pre-implantation genetic testing. With a publication list of more than 150 peer-reviewed manuscripts and chapters with a focus on long-term cardiovascular risk and mood disorders in PCOS, her research has been funded and recognized by the American Society of Reproductive Medicine, the National Institute of Health, the Reproductive Scientist Development Program, ISAR, and PCOS Challenge. She is a fellow of the PCOS Society of India, and she is also the past president of the PCOS Society, an international society focused on the subject of PCOS. She was an associate editor of the prestigious Journal of Clinical Endocrinology and Metabolism and is currently the associate editor of Endocrine Reviews. An author beyond par, I'm getting breathless just talking about her, for Harrison's Internal Medicine, and she has been selected as the Best Doctor Awards in America for several consecutive years. She has mentored over 20 trainees, some of whom have established PCOS centers and research programs. I'm happy to say that Anuja is an Indian born in Bombay, went to the KEM hospital. From there, she graduated and went to Oxford on a Rhodes Scholarship. She spent her time in Oxford, gained her PhD, and then moved on to Yale University and got her boards in OBGYN, and settled in the US. And finally, after that, she moved on to the University of Pennsylvania and set up this huge center for women's health, which included a lot of the areas which I've discussed before. So we are very proud of you, Anuja, as an Indian and as an American who went for a little space in the US, but has completely covered it into went into the state of Pennsylvania. I think that's what I can call you, not only the state, but maybe all of America. So we are congratulating you today on the fantastic achievement you have had recently, just a month ago, selected as the inaugural Founders Professor in Women's Health, which is the highest achievement you can have in academia. And Anuja is truly, truly fit for it. And I, from my end, congratulate her on behalf of the entire PCOS Society and Indians in India. So now I request Anuja to present her presentation on emotional wellness and lifestyle, and then we'll follow it up with a discussion. Welcome.
Thank you so much, Duru, for that wonderful introduction. And I am truly proud of my beginnings, both at GS and KEM, and thank you for giving me the opportunity to keep coming back and as being part of the PCOS Society of India and maintaining all of these connections. So it's great to be here today. As Dr. Shah mentioned, we have been working on the International PCOS Guidelines. This is the update now in 2023. And what I'm going to do as part of this podcast and video is review with you what we discussed in the Guideline Development Group 2, which was emotional wellness, and 3, which is lifestyle. So let's get started with what are primarily the updates from the last 5 years. And where we are with the first topic being prevalence, screening, and management of psychological issues and models of care. This was our group that met last November in Italy. And really, we have recognized, even with the earlier guidelines, that emotional well-being is a vital part and of PCOS, and manifestations of PCOS, really, they challenge our feminine identity and body image. And the features of PCOS that are concerning are the higher weight, hirsutism, acne, because there's enough data that tells us that this can now adversely affect mood and self-efficacy. It can compromise quality of life. And most importantly, it affects the woman's ability to effectively take part in lifestyle interventions. If you don't feel good about yourself and you don't feel good every day as you wake up, it's going to be hard to follow all the instructions that are given by our doctors. So we really view psychological screening and treatment as a very integral part of PCOS care. And then these were the priorities that we focused on for these guidelines. And the way these priorities get selected is we conduct a large survey of our patients and ask them to prioritize what is most important to them. And then matched with that is a survey of the physicians and the healthcare providers as well. So these were the 6 topics that were highlighted for the update in this GDG. Let's start with quality of life. And there are a number of studies that show us that the quality of life is reduced. So here under 0 with a minus number indicates a lower score for PCOS. And irrespective of the different screening tools that are used, like you can see here, they're all consistently showing that the quality of life is low in our patients. So that's the first thing that we need to recognize, that this disease state, PCOS, impacts quality of life. And once it does that, it can really impact how patients manage their symptoms and their perception of their symptoms. We don't have very good data in adolescence, but we assume that, a lot of this impact starts early on in life. And then we do have one PCOS specific tool known as a PCOS-Q, but it has certain limitations because it doesn't encompass all the different aspects that one would like to screen for. We're not recommending that clinicians use this as a tool on a day-to-day basis for their patients. It's more in terms of research studies where we use these and incorporate these tools. But important for you to realize that PCOS certainly has an impact on their day-to-day living. Going to the next topic of depression and anxiety. So we already knew with the first set of guidelines that there is a high prevalence of depression in adults. And my group had done some of the very initial studies and meta-analyses. This is now the updated data that we put together for the 2023 guidelines, that the odds ratio is 2.6-fold higher risk of depression in adults. And then when you look at the data in adolescents, it's 2.26 in adolescents. And this is new because we didn't have enough data in teenagers when we looked at the 2018 guidelines. Anxiety as well, now we have a lot more data compared to 5 years ago, all again supporting the fact that women with PCOS have a higher prevalence of anxiety, almost threefold higher than a control population. The data in adolescents is mixed though, and it's really not showing a consistent increase, very few studies. So what is the guidance at this point? So the way when you look at these publications, the EBR, so these are guidances or recommendations which are evidence-based. And then the CR is the clinical or the consensus recommendation. So here we have very good evidence to say that patients with PCOS have a high prevalence of depression, both in adults and adolescents, and that we should be screening them as a result. And then for anxiety, we're asking that we screen for anxiety primarily in adults because we do not have that validated data in adolescents. We want clinicians to screen patients when the diagnosis is made, so initially at the time of diagnosis. And then we're really not that clear as to how often do you keep continuing to screen patients because the longitudinal studies are lacking. And so as a result of that, the optimal interval for anxiety and depression screening is not known. But what we believe is that when there are comorbidities in life, when there are certain life events, such as the perinatal period, pregnancy, postpartum period, it's important to screen the patients. The next topic that we looked at is psychosexual dysfunction. And this is a paper that has just very recently been accepted for publication in Human Reproduction. And this is an updated systematic review and meta-analyses that inform the guidelines. And what the data shows is that women with PCOS, they report lower sexual function and lower sexual satisfaction. A number of these studies did not look at sexual distress, which is a different screen. And that's why we were not able to get a number for prevalence, but it's quite clear that the scores are lower in this population. So future studies really need to look both at the sexual dysfunction, but also distress along with it so that we can get some more concrete numbers. And so the recommendations here are that healthcare professionals should consider the different factors related to PCOS that can affect psychosexual function. For example, the higher weight, the body image with hirsutism, other mood disorders like anxiety, depression. Just the fact of having infertility can have an impact on their sexual function. And then perhaps some PCOS medications, maybe the birth control pills. And then we should really ask our patients about their psychosexual function, if it's impaired, and if there's any distress associated with it. The next topic was body image. And, body image is the way a person may feel, think, or, view how their body appears, and primarily appearance becomes a big part of it. We do know that many factors affect body image in PCOS, and these are PCOS-specific factors such as weight, hirsutism, acne, self-esteem. And there's great evidence now to say that healthcare professionals should be aware of that PCOS itself can have a negative impact on body image. And then finally, moving on to disordered eating and eating disorders. And again, we now have many more studies to support the higher prevalence of disordered eating in this population, with the odds ratio of about 1.53. And so the recommendation is that we should consider these conditions regardless of a patient's weight, but even more so important when we're counseling them about weight management and lifestyle. And what I mean by that is the nutritional counseling has to be geared specifically and personalized, especially when patients may have some underlying eating disorder. Because if you're going to recommend restrictive eating, calorie counting, that can put them into a vicious circle and worsen their disordered eating. So screening for eating disorders prior to nutritional counseling becomes a relevant part of PCOS care. Now, I reviewed all the different aspects and different types of mental health disorders that are prevalent in PCOS, and now coming to how are we going to manage them and how do we treat them. So once the diagnosis is made, the first line approach is psychological therapy, and really pertinent to how it's being managed in your own general population in India and whatever the resources might be. There's nothing that is unique about PCOS. And no studies have shown that the psychological therapy needs to be different than what the general population guidelines recommend. And then always bring into that counseling the fact that disordered eating can be a part of it, body image can be a part of it. And so the other aspects need to be brought into some of this counseling, and it shouldn't be restricted just to anxiety and depression. Although we say that psychological therapy is the first line, of course, antidepressants can be used wherever they are indicated. And what we did put into the guidelines was to avoid inappropriate use of antidepressants, and also be careful when those are being selected to make sure that they do not have any adverse side effects for PCOS. For example, some SSRIs can increase weight. So to be aware and cognizant about the side effects. On the other hand, we also know that some of the usual first-line treatments for PCOS, like birth control pills, metformin, laser hair removal, they can improve these psychological symptoms. So we as gynecologists should continue with management of PCOS symptoms, and then maybe partner with a therapist or psychiatrist for the management of their mood symptoms. But both of those need to move ahead in parallel. As part of this GDG, we also discussed a little bit in terms of how do we manage these patients and what is the best way and the best approach. So first and foremost, we need to prepare really good resources for these patients in terms of educational materials. They need to be high quality, they need to be up to date. And I'll show you some of the examples that are freely available for downloading from the Monash University website that were prepared as part of the International PCOS guidelines. This is really critical because patients have constantly told us through surveys that they're not happy with all the information that they get from their physicians. Sometimes physicians may not have enough time within very quick return visits to give all of that information, and hence making sure that you're giving handouts and giving high quality resources, websites, links is going to be critical. Is there a particular model of care that works best? It hasn't been shown as yet, and there hasn't been as much research. One would think that in this multidisciplinary disease state, it would be important that we have an interdisciplinary group of doctors taking care of them. Or it could be a primary care doctor who really helps to bring everything together, right? Because it's hard for patients to visit multiple doctors and have multiple appointments. Or should we have centers of excellence? And you know how you have a center for PCOS where under one-stop shop and one roof, the patient can get all the care. It really needs to be patient-centric care because, as you know, PCOS is a very heterogeneous condition, and no two PCOS patients really are the same. They come with so many different combinations of symptoms, and they prioritize different symptoms for each one of them. So we need to empower our patients, educate them, and really listen to what is their priority, what is bothering them most. And finally, recognizing that PCOS is a lifelong condition. It's a chronic disease. And it's not a one-time, let me give you a prescription of one medication and then you're going to be set, right? It's a chronic disease, metabolic complications may arise as they get older. The psychological manifestations may be there even when they're younger. The reproductive needs come up at some point within the years, and we're only beginning to understand more about the menopause. So this is a chronic lifelong condition, and both physicians as well as patients need to recognize that. So in the models of care, we did say that maybe the best way to do it is to have a primary care doctor who brings it all together, and then you can refer out to specialists or use a multidisciplinary approach. But we really need more research to tell us if one model is better than the other. I think, as you heard Dr. Shah say in the beginning, we're doing a much better job about awareness and a lot more societal awareness now, such that the stigma and the marginalization associated with PCOS has been reduced, but it's never enough, right? We need to continue to increase this awareness, make it very common to talk about PCOS. There's nothing to be shy or covering it up. Patients should come in early and seek care. It's not only about fertility, but it's also about cardiometabolic risk, psychological health, and just making sure patients understand that broad spectrum is going to be critical. And so here I just put in the link where you can get a lot of handouts for your patients. These have been beautifully prepared, pictorial, and at a level that most patients can understand easily. And if you click on any of these links, they also give individual separate handouts, and these are all free to download. But this is what I meant by we really need to give our patients high quality information. So those are the documents that came from the international guidelines. And so then let me switch to the second half. In GDG3, which was the Guideline Development Group 3, they spoke about lifestyle management, and these are the members of that group. And here is a picture. They got to meet in Australia last year. And so we definitely, even in our first guideline, have recognized that lifestyle intervention, which includes three things, right? Exercise, dietary intervention, as well as behavioral strategies. And these should be recommended to all our patients in order to improve their metabolic health. So that's one of the main reasons we are recommending lifestyle intervention, is because these patients have a tendency to gain more weight, and they have a tendency just to have more weight than somebody who doesn't have PCOS. So from a metabolic perspective, it's really important that we talk about lifestyle. But we've realized over the years of doing research that improving lifestyle behaviors can also improve quality of life. It can also optimize their general health, their reproductive health. And so for a broader reason, one needs to engage in lifestyle management. And this is therefore the sort of core focus of PCOS. As you hear me through the rest of the slides, there's no one set plan for all patients. So you need to co-develop this plan in partnership with the patient, depending on what she's done before. They may typically say to you, I have done every diet and nothing works for me. So you have to hear that and say, all right, let's hear it out and see what exactly have you done. And let's think of other opportunities. So the co-development is really critical. And even if you don't focus on weight loss, there are benefits. In the absence of weight loss, engaging in a healthy lifestyle will definitely give you benefits for PCOS. So again, broadly, making sure that we are not only focused on weight as a stigma, because that becomes a little bit of a spiral and a vicious circle, but talking more about healthy weight and a healthy approach, making sure that we talk about lifestyle management, even in those who may not be overweight, because if you're seeing them early as teenagers in their early 20s, there is a tendency to gain weight through the second and third decade of life. So making sure that you bring that in early on. And we put in this very last thing here, which is a practice point, is insulin resistance is part of that underlying pathophysiology for PCOS, but we're not recommending that you continuously monitor insulin levels. They should not be used for routine care. They don't really give us any guidance in terms of management of our patients, and there's great fluctuation in these levels depending on when they are drawn, even if they are drawn fasting, depending on what the patient ate the day before, stress levels, etc. So come away from excessive testing for that. Important to introduce behavioral strategies. And by this we mean is, how does a patient continue to engage in that lifestyle change, right? You don't want them to do a particular program for 2 weeks and then if it doesn't work, which is what they say, they stop, right? Because what are our goals? Things are not going to work within 2 weeks. This is not the goal here. The goal is to have a lifetime sort of sustainable change. And we refer to that as SMART goals. So short, very specific goals, things that you can measure, things that are achievable. You have to be realistic and then timely. And then in some patients, it's that cognitive behavioral therapy, because if there's underlying anxiety, if there's depression, you're going to need to use different strategies versus somebody who doesn't have the psychological health issues. So keeping that in mind is also critical. So to summarize, lifestyle management is first line. The focus really should be on preventing further weight gain, maintaining weight, and then maybe aiming for that weight loss, which should be gradual, maybe 5 to 10% over 6 months, but really very individualistic. And if you ask me, what is the dietary intervention that we should be recommending? The studies have not found that one type of diet is necessarily better than another. And that's not just the case for PCOS. It's the same for other patients who just are dealing with obesity and are trying to manage their weight. And hence, not to get trapped into the different fads and the different diets that usually come into vogue and then they go away. Important to advise things that are sustainable. You cannot do a meal plan which your family is not used to cooking in your kitchen every day. How long would you do something brand new for? A week, 2 weeks, maybe a month, but it's not going to be sustainable. So it should be tailored to your patient's needs. And that's what I talked about initially. It should be co-developed with the patient and really not to be unduly restrictive. We have found that backfires, and there's a lot of yo-yo. Patients gain weight, they lose weight, they gain weight, and that's very unhealthy for them. And maybe to use the clinically trained nutritionists, dietitians who are able to really handhold these patients, right, and help them through this journey. So sort of the summary for the diet part is no specific diet. Again, use those SMART tools and promote a healthy lifestyle. And then finally, for exercise, the same way, there's no one exercise that's been shown to be better than the other. And no one type or intensity, because there's a lot of this sort of on social media that the intensity of the exercise may be harmful or helpful. This really has not been shown, but advise exercise that's sustainable. And I think about it in two ways. The exercise could be either for prevention of weight gain. So if you want to maintain where you are, these are the recommendations of moderate and vigorous exercise for adults as well as adolescents. But on the other hand, if you are wanting weight loss, then as you can see, you're going to have to increase the amount of time that the patient is engaging in the activity and the exercise. So break it down into these categories of, does the patient need to just maintain where she is, or are we making recommendations so that they can actually lose some additional weight? And we did spend quite a bit of time talking about weight stigma and shaming. I think there's been a lot of focus with PCOS where patients feel that their doctors tell them you can lose weight and come back, and if you lose weight, your PCOS will get better. And that's really hard and frustrating for them because, as we all know, weight management is a major challenge. And that's why I think trying to shift away from stigmatizing weight is going to be the path forward, and really emphasized in this guideline, that we should look at weight just as one of the indicators. Look at their cholesterol panel, look at the diabetes number, look at the blood pressure, and make a wholesome assessment of their metabolic risk rather than focusing solely on the weight on the scale.
So thank you so much, Anuja, for that wonderful presentation. I think it has clarified a lot related to mental health and the importance of assessing the health of a woman who has PCOS. And these guidelines have made it very clear for everyone to understand why we need to assess and what we need to assess. So the question to you is that if we have to assess the mental health of a patient, I mean, what would you think is one of the best, tools one can use to assess depression or anxiety?
Yeah. So, amongst all the different things that we discussed, quality of life, depression, anxiety, disordered eating, psychosexual health, that's a lot to screen for so many things. If I had to prioritize, I think depression and anxiety are the two because they have the highest prevalence. And there are a number of screening tools for both of those. The ones that we use more commonly here in our PCOS center is called PHQ-9. So it's got just 9 questions. And that's an easy enough one for patients to fill. Sometimes you can have them completed while they're waiting to come back and see you for the appointment, once you check them in. And that way it'll be available for you when you see the patient. The recommendation right now is just to do it when you're making the diagnoses, not at every visit. That's a lot. And we really don't know how often do you do it, once a year, every other year. Those longitudinal studies are not available. But I would certainly do it at the time of diagnosis. And then if anything else changes, any other sort of life events where you think at a follow-up that maybe they are not adhering to the treatment. Maybe there's even more weight gain, and despite having made some recommendations, it may be reasonable to say, let's see what's going on and let's do a quick screen once again. So use whatever is more commonly used in your setup and what has been validated. But certainly the PHQ-9, I think, has worked well for us. And the quality of life scores are more research-based, and we are not recommending that clinicians use them on their regular basis in their practice. They give us a sense of what is the patient's most significant concern. Are they more concerned about fertility? Are they concerned about their weight, about their hair? But you can get that information just as you do your history and intake. And then for the disordered eating, psychosexual health, I wouldn't recommend doing detailed screening tools. That's going to take up a lot of time. But as you talk to your patient, if you're suspicious that they are at risk for one of these and you want a more in-depth evaluation, then for sure there are validated tools. But I would choose the one for depression or anxiety as our 2 leading ones to be done at least at the time of diagnosis. That would be a great start. Most of us are not even doing that right now. So
Yes,
if we even
absolutely.
get that going, it would be important for our patients.
So that's exactly what I was wanting to tell you, that during COVID, when everyone was under a lockdown, we connected with our PCOS patients because we normally would do their mental health assessment through the same tool as you have mentioned. And we found that those who had COVID compared to the ones who did not have COVID, the same PCOS patients, we found at least a 20% difference in the amount of mental health issues they had, more of depression, more of anxiety, and mainly related to their cosmetic changes. I think that was the biggest bugbear, and they were not able to go and get their laser done. They were not able to get waxing done. They were not able to do the cosmetic solutions which they would have normally done, nor could they do any exercise. Those who lived in small homes where they couldn't exercise, they could not even eat the diet food which they wanted to eat because the same meal was cooked for everyone in the home. So it was almost a long time that girls really did suffer a lot of depression and anxiety. So coming to the fact that yes, we do have assessment of depression, anxiety, etc. If you have seen patients with depression or anxiety, is there any clue you would get when you speak to them that this girl is likely to be depressed? And this is mainly for our clinicians who normally see patients. What are the most common points you would suggest to look for?
So with depression, the usual clues are sort of a lack of interest, not wanting to engage and do things, not getting a pleasure out of things. Sometimes it's just, I'm tired and I'm very sleepy. And then, of course, you have to rule out, is it hypothyroid? Are there other issues there? But
Yeah.
so there's a big overlap between just general constitutional symptoms and depression, or sometimes it can be quite clear. On the other hand, anxiety, you can tell. That's the way they come and they interview with us, and the repeated questions that they're asking. They're so anxious about their diagnosis. It comes through. Some of them do emotional eating. I always ask that question. Do what happens when you're anxious? What's your go-to? Oh, I eat,
Yeah.
Or when I'm watching TV in the evening, I just binge eat. So nighttime eating is another one that they engage in. So some of these just common questions might give us the clues as to what an underlying issue might be. And again, we don't want to label everybody with the diagnoses. And if the score is high, it doesn't mean they have the full sort of DSM-5 definition of major depressive disorder, right? All we are saying is you're scoring high on depressive symptoms. And just as you said, Duru, sometimes these symptoms can be because of body image. And then that makes them more depressed, which is exactly what you described in COVID. And that's really the study that our fellow Snigdha did. She's now at the University of Rochester, runs her own PCOS center. But what she showed was that a lot of the anxiety and depression scores, they were high, but if you adjusted for that, for their body image score, then it goes away. So really the body image distress was driving that anxiety and depression. And so being able to focus on the hair growth, the acne, just how they look and how they feel is very critical. It's as part of her study, it was very interesting. We showed them 5 images, from a sort of lean to an overweight image of a woman. And you say, where do you think you fit? And most of them circle themselves much heavier on the image than they are. So their perception of how they look is a lot more exaggerated than they even really are. So there's definite distress and a misconception that you have to help sort of, and that's why I think we need to take away the stigma, because I think that feeds into the anxiety in this population.
Absolutely. I totally agree with you. And the other point I wanted to discuss was that there have been patients who are depressed, who would probably go into self-harm or suicidal tendencies. I have not come across any such patients. I mean, maybe very, very rarely. But again, do you see it quite often in the US?
We don't. And that is really the distinction. So in all my years of practice, which, is just as long as yours, Duru, given that, that the center sees so many PCOS patients, I can really recall a couple that I might have had to say, oh, we need to send her to an emergency room. This is really serious. But otherwise, and that's really what we want to highlight, is it's not the kind of clinical depression where they're going to be on 1, 2, 3 medications poorly controlled. It's more higher depressive symptoms and just about getting into that diagnosis of a clinical depression. And hence, I think if we are able to catch it sooner and address factors that are causing it, we might be able to correct it for this population. We're not seeing suicidal rates or anything as extensive as that to a higher extent in the general PCOS population that we see.
Yeah, I think that is a similar experience over here with us. Coming to the next question is that when you talked about psychosexual function, quite a few of these PCOS women are hyperandrogenic. And there has been a question about whether they are more sexually active as compared to, or they are more, have more sex drive as compared to non-hyperandrogenic girls who have PCOS. Is there any sort of any relationship to that? The reason I'm asking is because when we use some of the drugs, like say we use the oral contraceptives for them, they do tend to complain that their sex drive is much less. They do tend to complain that they have a lot of dryness in the vagina. So whether it is actually suppressing the androgens which is causing the problem, or whether it is, I just want a sort of a clarity on this part.
No, and this topic comes up very often. And I think the first thing sort of to review is that the androgen levels in patients with PCOS are just above the normal cutoff. It's very rare that you even see somebody with twice as high, maybe 1.5 times as high as of the total T, but it's really not more than that. It's nowhere in a male range, absolutely not. If you see that, you have to think about tumor or cancer. So it's only marginally elevated, if at all. And so the studies do not support increased or hypersexuality based on that. And in fact, most of the studies show either decreased sexual desire, and that might be related to their body image. They don't feel good
Yes.
about themselves. And so they don't
Yes.
want to indulge in any sexual activity because they're not feeling good about themselves. So it may have nothing to do at all with the hormones, but we don't
Yes.
know that for sure. And that's why I think the paper that just got accepted was really important, at least to show on a number of the different scores, it's the same. There's no difference between PCOS and controls. And then in some, it's lower. Nowhere was it higher. So I think that part we feel comfortable about. And then in terms of the second part of the question you asked us about when they're on birth control pills, right? But that's common in anybody, even the non-PCOS population. When you use
Yes.
birth control pills for contraception, there's going to be a small proportion, not the majority, who might complain about a decrease in sex drive, the vaginal dryness. And that is not related necessarily then to just the androgens being decreased, but it's a complaint. And if they say that,
Yes.
either I lower the dose of the estrogen, the pill, and try to give them as low a dose as possible, or then try to talk about other ways of managing their symptoms.
Yeah. So that's exactly what I was coming to, that there are drugs which can cause problems with their sexuality, and oral contraceptives has been one of the products which has been mentioned, which we also see in a non-PCOS woman. So it really doesn't have anything to do with their androgens. So I wanted to highlight that point and bring it out to you.
Right. And I think again, if I may just highlight, Duru, that the idea that the androgens might increase sex drive comes a little bit from menopausal women, where there's this idea if you replace testosterone, they might have some improvement in sexual activity. And that comparison is very different because in the menopausal state, both your estrogen and testosterone are so much more lower, and then you're trying to bring it into maybe a normal range, right? So that's a very different comparison to where PCOS patients are and slightly above the normal range. So I know where these conversations have come from, but they don't always compare the same population. Yeah.
Absolutely. There's also a thought about self-esteem. You see women who are having a lot of hirsutism, they have a lot of acne, they have cosmetic issues, they have obesity. They tend to feel a little less, sort of good about themselves, which we have already discussed. Is there any way you can identify such women who you think are, thinking of themselves as having less esteem for themselves?
Yeah.
Would you be able to identify them clinically?
Yeah. I think, a lot of this comes up when they meet with the therapist and have those in-depth conversations. It's usually harder in our short, very quick clinical visits, with the physicians to go into all of those depths. But for sure, I think we have a good recognition now that once you see a patient who's obese, who's shaving, a lot of my patients will say by the end of the day, I can see the hair again. This is just too much. And you can do a PHQ-9, you can get depression scores, but then to keep going down the path in terms of the self-esteem, body image, this is where I feel we need that multidisciplinary approach. We need somebody who can give the patient enough time where they feel comfortable to speak up. Some of them are shy and they don't even want to share all of this with you. It may not come up at the first visit. It may not come up at the second, right? It takes a rapport and getting to know your doctor where you feel comfortable. And that's where I think the multidisciplinary, where people are trained to extract this and then support the
Yes.
patient, becomes quite
Yes.
critical. Yeah. So I think it's a little hard to give very quick, these are your two questions, and let's get to it, because this is so nuanced, right? And it's been affecting our patient for so many years that you can't solve it within a day for them.
No.
So having a more holistic approach is going to be important. Yeah.
You have to spend a lot of time with them and discuss with them. And there was this one patient of mine, even long after COVID had gone, she still came to the clinic with a mask on. And I told her, why are you still wearing a mask? We'll remove it if you like. So she says, no, doc, this is a great thing for me. COVID has done a great thing for me. I can hide my face because I have so much hair on my face. It was very, very sad to hear that. And she says, by the end of the day, my hair is almost like a man's beard. It's that bad. So these are the small things which I have found that, they are really apprehensive about. And the fact that she doesn't want to show her face because of the hair is really upsetting.
Yeah.
When it comes to eating this, yeah, go ahead. Sorry.
I was going to say what we also saw with, we had the same issues our PCOS patients had with COVID in this country, but with the mask, their acne got worse, and they used to call it maskne. And behind the mask, because the sweat, right? And it gets trapped the whole day, your pores are not breathing through.
Yeah.
And so it's both ways, right? Some want to cover the hair, some just didn't want to deal with this mask because the acne were getting worse. It was a very difficult time for PCOS patients. And you're absolutely right. They gained so much weight. The weight gain was the biggest challenge that we saw because nobody was getting out or just didn't feel motivated to work out, Yeah. So these were difficult times.
Very difficult. Coming to the eating disorders, we have anorexia nervosa, we have, bulimia, we have all these disorders with eating. Of course, there is a scientific reason to it as to why it occurs. And is there any way we can sort of course, therapy would help in terms of counseling, etc. But is there any other medical way we could help them?
Yeah, so the prevalence of anorexia, we do not find the prevalence of anorexia to be high in PCOS. The more common one is binge eating disorder. So, and they may go back and forth between not eating, restrictive, and then eating too much. And that's the commonest one. When you look at prevalence, I was saying to you earlier that anxiety is like 40, 50% of patients have it, depression, 20, 25, 30%. The binge eating disorder is a much lower number. It's 3, 4, 5%. It's not a very big number. And therefore, I think at this point, more being aware of it and more making sure as the nutritionist or the doctor, whoever is recommending dietary interventions, keeps that in mind and doesn't worsen it. Because sometimes we just make it all worse by giving a very strict diet and asking them to strictly follow things. That's what really gets them into a spiral. But if it is excessive, like, they are forcing themselves to throw up and doing all of those actions, then they do need the psychiatric intervention. I think then it's beyond our realm of managing when it gets to that point. But I do want to emphasize, just like the suicidal part, right, of the depression, this is not the common manifestation, but being aware. So the difference between an eating disorder and then disordered eating. So the eating disorders are, as you mentioned, anorexia nervosa, bulimia, binge eating. And then there's a whole spectrum of disordered eating where people become restrictive for some time and then, they're binging for some time, but all in a mild way. And that's really more of what we see in the PCOS population. And we don't want to escalate that and ever make it severe. And that's what, I think we want to increase that awareness amongst the people treating this population.
Yeah, they have huge cravings for a certain type of food, especially sweet, sugar.
Yeah, very common. And that craving comes like at 11 o'clock and at 3 o'clock, 4 o'clock, is a typical one. Those cravings can be very well managed by dietary modifications. So if you increase the protein and look at the plate and your proportion of protein goes up, simple carbs go down and keep complex carbs, you get more satiety and it'll cut out the craving. inositol and metformin also cut out the cravings, and that's why some patients like them. And that is not a disordered eating. That is just the fluctuation into, the hyperinsulinemia, then the responsive hypoglycemia, then they're hungry. And so if you do smaller frequent meals or do more protein, so they're just different strategies of cutting out cravings. And again, working gradually with a nutritionist, trying to figure out what in your diet will help you. I always say to patients here, when you think about a fruit, we say it's healthy, but the fruit really goes into your simple carbohydrate category. So with the apple, put little, in this country, peanut butter is so popular. So, the nuts, if you do nuts with your fruit, you'll get the protein. So always think about, where is my protein, and am I eating just a simple sugar? Because that's going to make it a lot worse.
That's very true. So I think we've had quite a great discussion on the mental health of women. I have a last question for you, that how can we support these women, and what has been the demand of PCOS women in your experience, since you run the center, and what do you find the most common things what women want in your country?
Yeah, and it varies a lot based on the patient's age as to what their needs are. The younger patients more interested in their weight management and appearance, then in the middle age group in fertility, and then as they get older, more interested in their cardiometabolic health. I don't want to get diabetes. What's my cholesterol? The patient can think about it that way, but I think it's our job to sort of make them aware of all of it from the very beginning, because you don't want to start so late with certain things and start increasing that awareness. And so what is the best way to do that? Because that's a lot, right? To be talking to them about all these things in one go. It probably is like, okay, they don't hear anything then. So giving it in piecemeals, and maybe, having different people give that information, because it gets reinforced rather than the same person just talking it through. And hence the help from the nutritionist, hence the help from somebody who can talk about mental health, hence having a GP who would talk about the regular diabetes, cholesterol. I think it reinforces, but it's hard. Then the patient has to go to so many different doctors. I do find that telehealth has improved access, and a lot of what we do, we don't need to do an exam on our patients. If you've got your ultrasound, you have the history, we can do telehealth consults and impart the information. The compliance is better. They come for the visits. There's more of a sort of less of a no-show rate, and they'll attend them. So using these newer strategies of helping them between our visits. I think as doctors, we have only so much time we can give them, but for this particular disease, they need other healthcare providers to connect the dot between the 3 months, 6 months that they're not seeing me. They need someone else to help answer questions, manage. And that's where I think we have to find innovative ways. There are a number of models of care where there are text messages going out to these patients to remind them, or there are coaches that'll help them. I'm very open to all of that, because I think it's so important to give patients whatever help, but good quality, high evidence-based care, which is important. I have a Twitter account, or X now, where I have started, because it's so frustrating. Even now, patients have such misconceptions about PCOS. So once a week, I tweet out myths and misconceptions, trying to set it right, because it's a shame that even after 80 years of describing the Stein-Leventhal syndrome, people still think there are cysts in the ovary. The diagnosis is based only on, I have gained weight, I'm not losing weight. So we still have a long ways to go. I think we've done very well with guidelines, but at the basic core level, which I'm sure you know all of this because you see these patients as well, Duru, but we still have a lot of misconceptions, and we need to give better care.
Yeah, so actually from the PCOS Society of India, I'm happy to let you know that we run a program called Vijayata, which means the winner. And we go out to corporates, we go out to colleges physically. Our members are doing a tremendous job. And for the last 9 months, we have been going out, addressing women, talking to them about PCOS, and engaging them in all the aspects. Depending on the audience, we decide what to focus on more. But lifestyle and nutrition and exercise is a must for everyone. And then we we get forms filled to get an idea of which are the ladies who are likely to be having PCOS. We conduct a multidisciplinary webinar for them so they can ask all their questions. They can get them sorted through a virtual meet. And it's working beautifully. And I think we will have quite a bit of data collected at the end of 2 years, hopefully. And I will pick your brains on what more I can do with that. And
this is amazing. Yeah, this is excellent. I think every which way that we can get to the patients is important.
We reach out to them on social media. We reach out to them on Instagram. And mainly most of our women are on Insta and Facebook. The Twitter is not very common with them. It's more with the career women, the Twitter. Otherwise, it's not so much. Anyway, it's been a pleasure meeting and talking to you, Anuja. It's really a pleasure. And we do hope to see you soon in one of our meetings, and hoping that we can get more out of you and hear more from you. So thank you very much for being with us today, and wishing you all the best for the years to come.
So much, Duru. Thank you so much for giving me this opportunity.
Thank you. Thank you. Bye. Bye-bye.